Good day, everyone. I am Dr. Grace Alferos from the Department of Medicine Section of Endocrinology, Diabetes, and Metabolism. This is one of the lectures in your endocrinology module in your internal medicine class. For this 2.5 hours, we will discuss the pituitary gland disorders. This is the outline of the lecture. The content of this lecture comes from the latest edition of your Harrison's Internal Medicine textbook. And some of the contents that will be discussed on the some guidelines that have been updated. Okay. We will talk about the pituitary gland, its function, and also its disorder. First part would be the anterior pituitary disorders, talking about mass of the pituitary, hyperfunction. We will focus mainly on the common ones, which are Prolactinoma, Acromegaly, and Cushing's disease. We'll also tackle the hypofunction of the anterior pituitary disorder, which will entail the deficiency of the growth hormone, the thyroid-stimulating hormone, the adrenocorticotropic hormone, and the Gonadotropin disorder. The last topic would be the posterior pituitary disorder, both its hyper and hypofunction, which is the syndrome of inappropriate antidiuretic hormone secretion, as well as diabetes insipidus. The pituitary gland, if you recall in your neuroanatomy, is this structure that lies in your sella turcica. And you know that the anterior pituitary and the posterior pituitary are invaginations coming from your nerve cells, as well as the invagination of the anterior pituitary that comes from the tissue, brain tissue. Now, the anterior pituitary is mostly vascular. So if you would see this one, there's a lot of vascular supply here. It is because you know that hormones would be distributed all over its target organ through the bloodstream. Your anterior pituitary will have different hormones, and the most common and the most important ones are your growth hormone, your adrenocorticotropic hormone that usually affects your adrenal cortex, your thyroid stimulating hormone, which mainly controls your thyroid gland, the gonadotropin hormones, which are your follicular stimulating hormone or FSH, and your luteinizing hormone or LH that has effects both on the male reproductive organ, which is the testis, and the female reproductive organ, which is the ovary. And then prolactin involves mainly your mammary gland. Your posterior pituitary will have at least two important hormones, which are the antidiuretic hormone, which is the ACTH, that affects your kidney tubules, as well as the oxytocin, which is mainly important in your mammary gland and uterine smooth muscle contraction. Now, it is important for you to know that each of the cells of your anterior pituitary would produce a specific hormone. And this specific hormone would act on a specific organ or tissue, and it will affect a specific function. So your lactotropes will produce your prolactin, and this will affect breasts mainly for milk production. your somatotrope or your growth hormone will produce your growth hormone mainly affects the liver and other tissues. It has the also has an effect on your IGF-1 or your insulin growth factor 1, which is somehow mediates the function of your growth hormone. And this will induce growth hormone induction and some insulin antagonism. Your corticotrope is mainly producing your adrenocorticotropic hormone, which affects your adrenals, producing the cortisol, which is mainly for steroid production. Your thyrotrope then will have your thyroid stimulating hormone, which mainly affects your thyroid. The main hormone would be a thyroxine. This is for thyroid hormone synthesis and secretion. And your growth gonadotrope, which are mainly your follicular stimulating hormone and your LH, as well as taking its effect on your ovary and your testes, in which will affect also your estradiol production or estrogen production and your testosterone, mainly for follicle growth and germ cell maturation, so affecting your reproduction. Okay, so it's also important to know that the percentage of of cells will differ depending on the hormone. What is the clinical implication? Because usually, if like the growth hormone, which is the most abundant of the anterior pituitary cell, so that's somatotrope cells. So it's majority of the cell. Usually this somatotrope, if they grow, they usually are big tumors. And your ACTH comes from your corticotrope, composes about 20% of the pituitary cells. And gonadotrope only about 10%, and the thyrotrope, which produces a TSH, only about 5%. So you would know that mainly this, especially the ACTH, when a tumor grows, usually is very, very small. Okay. Now, the other concept that you should know about the pituitary gland and its function is that they are intricately connected to other hormones. That's why most of the hormones in the anterior pituitary are influenced by a releasing factor, causing an increase of the hormone, and a suppressing factor, which causes a decrease in the hormone. This is very important so that the function of your anterior pituitary hormones would be in balance, because any imbalance, like an overproduction of one hormone, can cause hypersecretion and hyperfunction, and a decrease in the hormone will cause an undersecretion and will cause hypofunction. So let's go one by one. Most of the hormones here in the anterior pituitary will have its own releasing factor that is usually situated in your hypothalamus, except for a few. Okay. And also, one of the general concepts here is that the target hormone, which is in the target organ of this anterior pituitary hormones, usually will cause a suppression of the anterior pituitary hormones. So this is the concept of negative feedback, which we will talk about as we go on. So your growth hormone will have its growth hormone releasing hormone, and the one that usually causes its suppression is an inhibitory factor. Okay, so now also for the release of the growth hormone would be ghrelin and your estrogen. Okay, for suppression would be one of its target is IGF-1, and also chronic glucocorticoid secretion. For ACTH, the one that usually controls it would be the corticotropin releasing hormone. But other factors like the AVP, tumor necrosis factor, interleukin 1, 2, and 6, or leukemia inhibitory factor are also the ones releasing the ACTH, as well as physiological, psychological stress, exercise, illness, insulin-induced hypoglycemia. And you know that your ACTH would release the glucocorticoid, and you need this glucocorticoid to be released to fight off stress, illness, and also hypoglycemia. Now, for your gonadotropin, which are the FSH and your LH, the gonadotropin releasing hormone is the main releasing factor. However, rising estrogen, which usually occurs in pre-ovulation of females, will increase this one. Okay. However, a chronic estrogen and progesterone will cause inhibition of your gonadotropin. So it says here chronic because this one is a rising estrogen. It would be a different effect. This chronic estrogen and progesterone is actually one of the reasons why uh, OCP would suppress your gonadotropins and causing its effect of not having any ovulation. Another factor would be activin, but this is mainly for your follicular stimulating hormone. And it also has its inhibitory factor, which is inhibin. Now, thyroid stimulating hormone will have its thyrotropin releasing hormone also from the hypothalamus. Now, factors that would cause an increase in the TSH would be from your negative inhibition. And that is if you take out your thyroid through thyroidectomy, radiation, or thyroiditis, which is an inflammatory process, as well as any goitrogen. Now again, its target hormone, which is the thyroxine, will inhibit the TSH, as well as dopamine and somatostatin. If you look at the suppressing factors here for your anterior pituitary, you will see that glucocorticoid will suppress your growth hormone, your ACTH, as well as your TSH. Okay, so that one is a very important concept that you should know about glucocorticoid. Okay, now the actions of the different hormone, you should know to know what will be affected when there is an excess or if there is a deficiency in function. By its name, your growth hormone will induce protein synthesis and nitrogen retention, and this is needed for growth. It antagonizes insulin, that's why it may cause impaired glucose tolerance and later on diabetes if there is an excess. It can stimulate lipolysis, increase fatty acid, decrease mental fat, and enhance lean body mass. It promotes sodium, potassium, and water retention, as well as an increase in inorganic phosphate. It also stimulates epiphyseal precondylocyte differentiation, which is needed for your vertical growth. Now, the ACTH, or adrenocorticotropic hormone, induces steroidogenesis. And this is mainly to maintain adrenal cell proliferation as well as function. In the hypopituitary adrenal axis, it also maintains a metabolic homeostasis. A lot of the functions of the ACTH would be helping promote metabolism of a lot of functions in the body. It also mediates neuroendocrine stress response. So this is a stress hormone. For the follicle stimulating hormone, mainly, so you remember it's for follicle development and maturation. as well as estrogen production. And for males, seminiferous tubule development and spermatogenesis. So I usually remember this one as the F for follicle and the S for the seminiferous and spermatogenesis. Okay, so FS. Okay. And for luteinizing hormone, it's mainly for ovulation and corpus luteum and Leydig cells. So remember, the L here would stand for ovulation, luteum, and Leydig cell for testosterone synthesis and secretion. And lastly would be your thyroid stimulating hormone, which will stimulate your thyroid hormone synthesis and release. Now, what type of disorders can occur in your pituitary? So, what are the mechanisms? How will your pituitary become disordered? Okay, so there can be an excess of the hormones. As I've mentioned to you, if there's a disruption in stimulation, the stimulation would be in excess, then you can have hormone excess. If there is hormone excess, then you will have a lot of these hormones and its function would be too much or would be evident in the parts of the body that will have an excess, okay? Now for hormone deficiency, so its function of the hormone, if there is, let's say, a suppression or you have your releasing or your stimulating factors taken out, then a lot of times it will lose its function. And the last one is hormone resistance. So the hormone resistance usually in endocrine matters means that there is the presence of the hormone. However, in your target organ or in the end organ, it is not functioning. So there can be a block in the receptor, or there can be a loss of function. So what happens is that there's a lot of hormones that are being produced or enough hormones, but the target organ is not functioning. Okay, there can be a block, okay, or sometimes it might be just it needs more of the hormones to maintain its function. One of the important hormone resistance that we see is not in the pituitary. The mechanism usually happens, the hormone resistance usually happens in insulin. So there can be insulin resistance wherein there's normal levels of insulin. However, there's an increased resistance in the target organ. That's why it's not working. So that happens in type 2 diabetes. So that's the one of the common resistance patterns that we see in endocrinology. In your pituitary, it may happen, but it is very, very rare that you will have a hormone resistance. Okay, so as I mentioned to you earlier that your hypothalamus and your pituitary and the end organ are basically in a harmonious relationship. Okay, so it is controlled by a feedback mechanism. That's why the hormone doesn't go in excess, because it is being checked by your end organ. It's like your it's like three different things or offices that are continuously communicating with each other such that they would function harmoniously. However, your hypothalamus and pituitary and your peripheral gland might have some problems, and that will be the start of your disorder. So the two main pathologic disorders that we can have would be an excess, which is the hyperfunction of your pituitary, and hypofunction. Okay, so the feedback mechanism usually looks this way. So there's your pituitary gland. And if you have a pituitary gland, so this pituitary gland has an excess hormone. Okay, so let's say there's a tumor that causes an excess in the pituitary gland hormone. So this would be increased. So your hormones would be increased. And this would, because of the feedback mechanism, this will signal the peripheral gland to also increase its hormone production because it's a stimulating hormone. Now, because of this feedback mechanism, okay, this will cause the hypothalamus to try to decrease the releasing hormone. Now, since this is elevated, and this is usually autonomous, this will continue on and on. That's why this will remain elevated and this will remain suppressed. So that's what happens if there is hyperfunction of your pituitary gland. Now, I place here, it might be normal or no change because usually on the early stages, this will not cause any suppression. Or sometimes there is a concomitant dysfunction because of a tumor. That's why this becomes normal. Okay, so it can encroach also on your hypothalamus, making an inappropriate hypofunction. Okay. Now, for the pituitary gland, if there is hypofunction of the pituitary gland, so your hormones will be low, that will send signals to your peripheral gland and it will cause target organ low secretion. And as a negative feedback, this will cause an increase in your hypothalamus releasing hormones. So that will go on. Again, sometimes it can be normal because on the early stages, this might not go up. Okay. So how do you approach a patient with a possible pituitary problems? The importance of history and physical examination should be emphasized. You have to evaluate symptoms mainly because the symptoms of a pituitary function are very generalized. It can be seen in other illnesses, okay? And also, you have to evaluate them thoroughly because there are some symptoms that are just generally pointing to one specific hormone. Okay, example would be for prolactinoma. Okay, so if it's an excess, you will have galactorrhea. That's very specific. Okay. Now, review of system, also important because they might just be complaining of one, but when you go to the review of system, they might not know that the other things that happen in their body will be related, like galactorrhea, amenorrhea. They don't know that there is a connection. Family history, a lot of endocrine disorders can be familial. Social history and use of medications are very important because a lot of drugs can affect your pituitary. Laboratory testing. This is very important because when you approach a patient, you cannot just order a battery of tests because in endocrinology, there are specific conditions wherein you should take the hormones on a specific time. Like there would be times that you need them to be getting a fasting hormone. Sometimes you will need some dynamic testing. So sometimes if there is hyposecretion, the dictum is you try to stimulate. And if it doesn't get stimulated, then it means that there is really hyposecretion. On the contrary, if there is hypersecretion, there is an excess hormone, you try to suppress it. And if it doesn't get suppressed, then it means that there is hypersecretion. Also, you have to take into consideration the state of the person. Like if the patient goes into hypoglycemia, you know that that condition will stimulate your hormones, and that would be the best time sometimes to check your stress hormones like your cortisol, your growth hormone, and that is a very important uh, uh, time and testing that should be done because it's very functional. Okay, and then lastly, the radiologic imaging. If you look at this one, radiologic imaging, what will be done last of this approach, because first you have to know which area you should be testing or you should be imaging, and for a specific condition there is a specific imaging that would be needed. Like if you think you needed pituitary cuts, you need to have pituitary cuts. If you think you wanted to see part of your hypothalamus, then you have to also do that one. Is it a CT scan that would be needed, or is it an MRI? A lot of times for the adrenal, the CT scan is better. For the pituitary, the MRI is needed. And sometimes you have to note also that you can also have just a plain or a contrast image. So that will also matter. Okay. Okay, so now let's go on to the different disorders of the anterior pituitary. So again, this is the outline. We'll talk about first the mass or the tumors, and then we'll go through hypersecretion. We'll just mention the ones that are very common in pituitary hypersecretion and pituitary hyposecretion. We'll talk about one by one because it is clinically relevant, because you would need to supplement them. Okay, so if you remember in your neuroanatomy, this is your pituitary here, this is your stalk, and above that one would be your hypothalamus. Note that your optic chiasm is superior to your pituitary. That's why that's a very important structure, because you can have visual problems if there is a mass in your pituitary. So here, if you look at this view, this is your pituitary, this is your sphenoid sinus, this is your sella, and lateral to it would be your important vessels. Okay, so you have your oculomotor nerve here, your trochlear, and your ophthalmic nerve, as well as your abducens and maxillary nerve here. Okay, and remember, I've mentioned to you, this is your chiasm superiorly, this is your third ventricle. Okay, now pituitary mass or tumor are common causes of pituitary hyper or hyposecretion syndromes in adult. It's about 15% of all your intracranial neoplasms. However, a small adenoma, which is less than 1 centimeter, is seen in about a quarter of your autopsy cases. So it's not that uncommon. And about 10% will be seen in a pituitary imaging. So if you image probably 10%, one can have a pituitary tumor. Okay. However, 1/3 of all the adenomas are clinically non-functioning. So probably you will see them that they have this mass, but it's not producing any problem. No clinical hypersecretion. Okay, so 1 out of 3. Now, if you are encountering a pituitary disorder or a mass, 3 things that you have to take in consideration so that you will not miss out anything. First is that if I have a pituitary disorder, especially if I have a mass, I would think of what are the signs and symptoms if there is a mass encroaching on the surrounding structure. This is what we call the mass effect. Also, because of the mass, am I encountering a hypersecretion of the hormone, or is there a hyposecretion of the hormone? Remember, there are several hormones. One can be hypersecreting, the other ones can be suppressed. Okay. So always take into consideration, if you have a pituitary problem, is there a mass effect? Is there hypersecretion? Is there hyposecretion? So what are these mass effects that I should be thinking about? So if the tumor goes up superiorly, then you can have problems in red perception, hemianopsia. There can be a bitemporal defect, scotoma, and some will also cause blindness. If it goes up further, then you can have problems with temperature, appetite and thirst disorders, obesity, diabetes insipidus, sleep disorder, and behavioral and autonomic dysfunction. Okay. Now, if it extends laterally to involve your cavernous sinus, then it will encroach on your cranial nerves. So you can have ophthalmoplegia, ptosis, so that would be cranial nerve 3, and diplopia and facial numbness, cranial nerve 5. If it goes anteriorly and superiorly, then it will encroach on your frontal lobe and cause personality disorder and anosmia. So you can have problems with smell. If it goes on further and encroach your third ventricle and the brain parenchyma, then you can have headaches, hydrocephalus, psychosis, dementia, and laughing seizures. That will be an extreme case. So now we go to the hypersecretion. So you know what the mass effect are. Let's now go to the hypersecretion, and we'll talk about the most common one, which is prolactinoma first, and the other two common ones later on. So prolactinoma, you know that your prolactin is, if you remember, I discussed the different hormones. Prolactin is a little bit different, no? It doesn't have a releasing hormone. It is actually uniquely controlled by your dopamine, and this is dopamine-mediated suppression. So imagine your prolactin doesn't have to be secreted always. It should be actually suppressed. Otherwise, we'll end up with a pool of milk, no? If this one is uncontrolled. So you know that its action is to induce and maintain lactation. So it's mainly for females, and also decrease reproductive function. So actually, when you take in consideration, if it maintains lactation, somehow you wanted lactation to continue and the reproductive hormone to be suppressed, because to nurture the child. So sometimes they said that if you breastfeed, you will not get pregnant. So it's because physiologically your prolactin will decrease reproductive function. Okay, and it also suppresses the sexual drive. So physiologically, that makes sense that if you just had a baby and you have to nurture that one, no? So reproduction is suppressed, as well as the sexual drive. So that is the main function of your prolactin. Now, hypersecretion, okay, of this prolactin is the most common pituitary disorder, okay? And usually a prolactin level of 100 microgram per liter is mostly due to a prolactinoma. Why am I telling this? Because your prolactin can get elevated. In some centers, the cutoff would be around 30 microgram per liter. Some would be 50. So usually double or triple the level of the prolactin is mainly due to prolactinoma. However, during pregnancy and lactation, this can increase physiologically. Now, as I mentioned to you, hyperprolactinoma can present with amenorrhea, galactorrhea, infertility. However, in those who are not in the reproductive age group, it can cause a decrease in vertebral bone mineral density, causing osteopenia and osteoporosis, decreased libido, weight gain, and mild hirsutism. Now, an elevated prolactin is not always due to a tumor in your pituitary. So what are these possible causes of increased prolactin? Earlier, we mentioned about pregnancy and lactation. Chest wall stimulation is also causing hyperprolactinemia, sleep, and stress. Okay, so if you're stressed, this can increase. That's why if we wanted to check the prolactin, it should be a fasting level. And chest wall stimulation, we sometimes tell them to abstain from any sexual encounter before having a prolactin level checked. Okay, drugs are very important as a cause of hypersecretion, and it can be because of the dopamine receptor blockers. Okay, it can be due to antipsychotics like risperidone, phenothiazide, these are antiemetics, chlorpromazine and perfenazine, haloperidol, okay, so antipsychotics, metoclopramide, dopamine synthesis inhibitors like methyl-dopa, which is a use for blood pressure, reserpine, cimetidine, ranitidine, and verapamil. Other causes would, the pituitary hypersecretion mainly is from a prolactinoma, but acromegaly, which is from a growth hormone excess, can also cause hyperprolactinemia. This is because the parent hormone for prolactin will be including the growth hormone, okay? And also systemic disorders like renal failure, hypothyroidism, liver cirrhosis, pseudocyesis, and epileptic seizures can cause hyperprolactinemia. So if you're thinking that the patient can have has this disorder, you have to rule this one out before you say it's a true hyperprolactinemia from a pituitary hypersecretion. Other causes would be a hypothalamic pituitary stalk damage, and this is what we sometimes say a stalk effect. Okay, so because the dopamine suppression is related to coming from your hypothalamus, then anything that can disrupt the connection between the hypothalamus and the pituitary can cause an elevation in prolactin levels. These are tumors, hypothalamic tumors, craniopharyngioma, or other tumors within the area of the pituitary, like suprasellar tumors, meningioma, germinoma, metastasis, an empty cella, lymphocytic hypophysitis, granulomas, cyst, irradiation, trauma, pituitary stalk section. So this one can be surgical, okay, suprasellar surgery, or it can be due to accidents. So you have to rule this one out before you zero in with pituitary hypersecretion. Now, these are the clinical manifestations that we've mentioned. So mainly in women, hallmarks would be amenorrhea, infertility, and galactorrhea. Okay, this one is actually the most troublesome, the galactorrhea. It's present in about 80%. However, you can have decreased libido, weight gain, and hirsutism. Visual field defects or other mass effects might also be seen, so you have to also consider that one. Now, once you suspect there is excess prolactin, then you have to do investigation. And the main thing that you have to take in consideration would be the level of prolactin, which is usually a fasting prolactin level. Sometimes we need to do it a couple of times to make sure that it is elevated. So if it's prolactinoma, you're thinking about more than 100. Okay, and also TSH and FT4. So you remember in one of the causes, systemic causes of pituitary prolactinoma under the prolactinemia, hyperprolactinemia, I mean, is a hypothyroidism. So you have to exclude this one by getting the TSH and FT4. And usually, what happens is that the TSH is elevated and FT4 is low. So you have to correct this one to really get the picture of your prolactin level. And then the other things is, again, if you think there is other hormone excess and also underactive in other hormones, then you have to check that one. But the main ones are this. And then lastly, you have to do an MRI. So MRI say specifically is for the pituitary, so you will get specific cuts in your pituitary. Otherwise, you will not get a specific cut in your pituitary. Okay, so if the prolactinoma is small, okay, then you might miss it in MRI if you don't say it's a pituitary MRI, because a pituitary MRI will cut through your pituitary. Brain MRI will probably just cut one or probably just above or underneath if the pituitary is normal size. Now, how do you treat prolactinoma? This is important because this is medical. So most of your hyperprolactinemia or a prolactinoma is medical. So the mainstay would be a dopamine agonist, which is what's available here in the Philippines is your bromocriptine. And then you also have cabergoline, pergolide, lyseride, and quinabolide. So the ones that's mainly used is the bromocriptine. We usually titrate up as the patient can tolerate, and then to maintain the prolactin at normal levels. Okay. Now, when do you do surgery? If there is dopamine resistance or intolerance, the patient cannot tolerate the bromocriptine. The main intolerance stems from its side effect of hypotension, nausea, and vomiting. Okay. Now, surgery is also indicated if there is an invasive macroadenoma, especially if you have a visual compromise, because you cannot wait for the tumor to shrink. Otherwise, the patient will end up blind. So if it is an invasive macroadenoma, macro means it's more than 1 centimeter, then you have to do a surgery. And usually the surgery that we do is a transsphenoidal surgery. Okay. Now, if this is not successful, then you can do radiotherapy. So that is usually the last one that you can do for a prolactinoma. Now, let's go to the second, which is the acromegaly. The growth hormone is synthesized in your growth hormone secreting somatotube. As mentioned earlier, it's 50% or almost half of your pituitary cells. This is the most abundant anterior pituitary hormone, and they usually are big tumors if you have an acromegaly. The secretion is pulsatile, wherein it peaks with sleep onset. So I remember this one because when we were kids, we were told to sleep so that you would grow. And look at that. There is a basis in physiology wherein secretion is peaking at sleep onset. Okay. Now, IGF-1 is a potent growth and differentiation factor for your growth hormone. It indirectly mediates the physiologic effects of growth hormone. So they are like partners in crime. Now, this is very important because IGF-1 usually is not secreted in pulsatile manner like the growth hormone. So you can actually measure this one as a surrogate of the growth hormone function. So the actions of growth hormone, we've mentioned this earlier, mainly for growth. So protein synthesis, insulin antagonism, lipolysis, sodium, water, potassium, retention, and epiphyseal differentiation. Okay. Now, what are the causes of growth hormone excess? So growth hormone excess, majority would be pituitary. So about 98%. Now, it is extra pituitary tumor that you can see in some pancreatic islet cell tumor or lymphoma. Now, acromegaly can also occur because of the releasing hormone secretion, but this is less than 1% of all. So it can also be a hypothalamic hamartoma or choristoma, or it can be peripheral, seen in carcinoid pancreatic tumors, small cell, adrenal, medullary, and pheochromocytoma. So these one are quite rare. So if it's acromegaly, it's in the pituitary unless proven otherwise. So again, because of its function, it will present with bony overgrowth. Usually in the acral, you can have soft tissue swelling, acropathy, kyphosis, carpal tunnel syndrome, and proximal muscle weakness and fatigue. You can have deep, hollow voice, generalized visceromegaly. You can have upper airway obstruction with sleep apnea, so they have a lot of snoring. You can have heart disease, cardiomyopathy, arrhythmia, LVH, hypertension, diabetes, colon polyps, and malignancy. So there can be, this one are images of acromegalic patients. So you see that the hand, so they have big hands here. You can have frontal bossing. There's some coarsening of the facial features. So you can have macronathia. So this one, so you look, this one was before, and this is one with acromegaly. I can remember this one as a description of the coarsening in facial features of acromegaly. Parang sa dialect natin, sinasabi natin, parang pumapangit sila. Okay? So, para silang nagiging Shrek-like. So, no offense to those who like Shrek. Okay? So this one, these are tall twins, but the gigantism usually occurs before the epiphyseal closure. So in kids, the acromegaly is equivalent to gigantism. Now, how do you investigate? Okay, so earlier I already mentioned about getting the insulin-like growth factor 1 as a screening method because it's constantly elevated in the blood and doesn't follow a positive function. So you can, if this is elevated, that's used for screening test. But the gold standard is you really, if you wanted to confirm, is do 75 OGTT. So remember, if there is hypersecretion, you have to suppress them. And what can suppress growth hormone is an excess in your glucose, because hypoglycemia will stimulate it. So hyperglycemia will suppress it. So if it doesn't suppress to less than 1 microgram per liter, then that is a confirmatory of presence of acromegaly or growth hormones hypersecretion. So again, how do you treat this one? So unlike in prolactinoma, wherein you will have a medical therapy, if you have acromegaly, the first line would be surgery. And as I've mentioned earlier, these usually are big tumors. So you really have to do surgery. However, you can still do transsphenoidal resection. So this is the treatment of choice. However, if this fails, and there can be failure because they are big tumors, then you can give octreotide, which is a somatostatin analog, okay, to suppress your growth hormone. And if this doesn't cause further suppression, will not control the growth hormone, then you have to do radiotherapy. Okay, so pituitary radiation. Now, we'll go now to the last hypersecretion, which is Cushing's disease. Some of the things here might be discussed in overlap with your cortisol excess in your adrenal, but Cushing's disease is mainly a pituitary, okay, entity. Okay. Now, your adrenocorticotropic hormone, or ACTH, is about 20% of your pituitary cells. So your pituitary cell is your corticotrope. And it has a releasing hormone in your hypothalamus. And this is the predominant stimulator of your ACTH synthesis and release. Like the growth hormone, its secretion is pulsatile, so it has a pattern. So it peaks around 6 a.m. and it's nadir at midnight. So when you look at it at around 6 a.m., when you start waking up, you will need all your ACTH, all your stress hormones with you. It starts to decline. Usually at 3 o'clock, it goes down. And then, nadir at midnight, almost none at midnight because you're supposed to be sleeping at that time. Okay? So, it follows that circadian rhythm because that's the pattern that we should be doing. So you're up and about in the morning and you're supposed to rest at night. Okay, again emphasizing the importance of your hypothalamic pituitary adrenal axis here. So CRH, ACTH, and your cortisol. So metabolic homeostasis is maintained with this hormone as well as your stress response, and also production of your steroid to maintain your adrenal cell proliferation and function. So that's the main function. Again, you have to know that ACTH is released by your CRH, your AVP, and inflammation in leukemia inhibitory factor, stress, exercise, and insulin-induced hypoglycemia. So these are very important. And the one that suppresses it is a glucocorticoid. This is suppression in excess or above physiologic levels. Okay. Now, Cushing's disease, okay, is mainly a pituitary adrenocorticotrope adenoma. Cushing's syndrome is the excess in cortisol in the body. So if it is pituitary, coming from pituitary, which is about 70% of endogenous, it means the cortisol that is produced within the body. So endogenous hypersecretion, it's mainly a pituitary corticotrope adenoma or Cushing's disease. So syndrome, it means there's excess cortisol, but it can be due to other factors. And one of the most common causes of Cushingoid features, so the ones, the phases that we see, okay, is usually iatrogenic hypercortisolism. It means that if you give too much steroid hormone, like your prednisone, your hydrocortisone, then it can cause Cushingoid features. And this is the most common iatrogenic. Other causes would be an ectopic tumor causing ACTH production, cortisol producing adrenal adenomas, carcinoma, hyperplasia. So this one will be differentiated later on and will also be discussed in your adrenal module. And also CRH producing tumors are causes of Cushing's syndrome. So if there is an excess in your ACTH, okay, which is what you see in pituitary ACTH excess or Cushing's disease, then you will also increase your cortisol. Now, the presentation of Cushing's syndrome, excess in cortisol, will be the same both in your pituitary, adrenal, and peripheral. However, there are some important things that you have to take note that will differentiate a Cushing's disease from one that will be seen in other Cushing syndrome, okay, like mass effect. Okay. However, you will see them very common. You will have central obesity, a thin, fragile skin. You can have moon phases, purple stria, bruising, proximal muscle weakness, hypertension, glucose intolerance, and leading to diabetes and gonadotropin dysfunction. So it can also present as osteoporosis, hyperandrogenism like acne and hirsutism, psychological. So you can have depression, mania, and psychosis. It has hematopoietic effect like leukocytosis, lymphopenia, and eosinopenia. Immune suppression, so you have more infections, you can have delayed hypersensitivity, and cardiovascular disease is the main cause of death in Cushing syndrome. Now, how do you investigate? Okay, for all Cushing syndromes, if you see somebody with monphasis, sexual obesity, and then you have purplish stria, then the first thing that you have to do is to document that there is hypercortisolism. And how do you do that one? The screening test is a 24-hour urine-free cortisol. Okay, so you have to get the 24-hour. Why is it 24-hour urine-free cortisol? Because you know that there is a circadian rhythm. So even though it's a hypersecretion, there's still a circadian rhythm. So if you just get one sample and you don't do a 24-hour, you might be missing it. Now, the other thing that we do is, as I mentioned to you, if there's an excess, you have to suppress it. And how do you suppress it? So you give dexamethasone. So you give a 1 milligram dexamethasone, usually given at around 11, and then you have to measure the cortisol the next day. Now, if these two, your free cortisol and your suppression test, says that there is hypersecretion, then you can proceed to differentiate them. Either they have a problem with your ACTH, and this will differentiate if it is coming from your pituitary or it comes from your adrenal or ectopic. Now, ACTH independent, it means it's coming from your adrenal or exogenous, okay, will show that your ACTH is low or normal. But if it is ACTH dependent, it means it's the ACTH driving your cortisol to go up, then it can be a pituitary. Now we also have ectopic here because the ACTH can be produced in other tumors. Now, if you're not able to differentiate here, adrenal or pituitary or ectopic, then you can do an inferior petrosal venous sampling, wherein you get a sample from your inferior petrosal venous sample here and a peripheral, and you have to do an ACTH sampling. So what happens is that if you cannulate near the pituitary and one from the periphery, there should be a gradient wherein there is an increase in ACTH or cortisol in the level of your pituitary rather than in your peripheral. So if there's no gradient, it means whatever is the level of your ACTH cortisol in the venous sample near your petrosal, and there's also one in your periphery. If there's no gradient, it means it has no difference. Then it means that it is ectopic. So Cushing's disease. So if you're zero in that it's in the pituitary. So what happens? You have an increased ACTH. Cortisol is also high. Your inferior venous sampling will show that there's a gradient. No, it means that there's an increased level there in your inferior petrosal sample. And also, if you do an MRI, there's probably a tumor. We see Cushing's disease as one of the small tumors in the pituitary. So what you can do, the treatment of choice is surgical, like the one that you see in acromegaly. So this is a lot of times, this is done by transsphenoidal surgery. So that's the treatment of choice. Actually, this one, a lot of times, you don't really need to go to this one. However, if it's a big tumor, again, you can fail. You have about 15% cure rate after an unsuccessful surgery with pituitary irradiation. However, this is low and partially effective in adults. If these two fail, then you still have steroidogenic inhibitors, which is ketoconazole and metarapone and mitotane. They usually destroy your steroid function. Ketoconazole inhibits the production of your steroids. All right. Okay, we can have a probably a little break before we go to the hypopituitarism. I'll give a few, just 1 or 2 minutes. Okay, we'll talk about the hypofunction of the pituitary. So this means that there is deficiency or insufficiency in the anterior pituitary. Okay. Now, the possible causes of a pituitary insufficiency can be due to a developmental or structural problem. A lot of times this occurs in children. But it can be traumatic, it can be neoplastic, an infiltrative or inflammatory disorder like hypophysitis, can be vascular, part of an infarct or a bleed, or it can be due to infection. Here we have TB or HIV. Now, each of the hormone can be deficient. Okay, so we'll talk about the deficiency of each hormone, and you will see at the very end, we will summarize because there can be multiple hormone deficiency later on. Adult growth hormone deficiency or AGHD, okay, causes very non-specific clinical features. So there can be impaired quality of life, decreased energy, drive, poor concentration, low self-esteem, and social isolation. There can be body position changes, increased body fat, central fat obesity, waist to hip ratio is increased, and there's a decreased lean body mass. There can be a reduced exercise capacity, reduced maximum O2 uptake, cardiac function, and reduced muscle mass. Cardiovascular risk factors can occur, impaired cardiac function and structure, lipid metabolism profile is abnormal, fibrinolytic activity is decreased, atherosclerosis, and mental obesity. So if you look at these clinical features, I sometimes look at somebody who probably has been not doing well, okay? I sometimes liken it to a medical student who just doesn't look at his or her own well-being. So isn't it that being in medicine, you have impaired quality of life, you get body composition changes, and you seldom exercise. But this is not all. There are some exceptional medical students. But the cardiovascular risk factors are very important because this can be the silent killer of all. Now, so if you see that the signs and symptoms are very non-specific, so when do you need to check and when do you have to investigate further? So you only think of adult growth hormone deficiency and you do the laboratory test if these are the factors that are present, okay? Let's say there's a pituitary surgery that happened, or there's a tumor or granuloma either in the pituitary or at the hypothalamus. There was a previous cranial irradiation, not necessarily pituitary, it might be other tumors in the brain. Or there is a radiologic evidence of a pituitary lesion. So if there's a mass that you see in the pituitary, then you have to investigate. Now, if there's a child with growth hormone replacement therapy, so there was a previous growth hormone deficiency in childhood, then you also have to investigate. Or if there is an explained low age to sex match IGF-1. So if you measure this one and it seems that it is low, then that's the only time that you have to do the further investigation for adult hormone deficiency. So if you suspect that one and this criteria is met, then you have to investigate. Like hypersecretion, you usually probably can measure the IGF-1, but this one will not tell you that the patient is growth hormone deficiency. It might be useful if it is low, but if it is normal or elevated, it will not tell you. But IGF-1 is good as an index of therapy response. So because the signs and symptoms are very nonspecific, you cannot rely if you're adequately treated, then you can get the IGF-1. So the mainstay or the most validated test is an insulin-induced hypoglycemia. As I've mentioned earlier, the dictum for somebody who has deficiency is you try to stimulate them. So you try to stimulate growth hormone by making the patient hypoglycemic. And you do the insulin tolerance test. Usually you have to drop the glucose to hypoglycemic range, and then you get the growth hormone level. If the growth hormone level doesn't peak beyond 3, then this is adult growth hormone deficiency. So once you've documented that there is ADHD, next one is you have to treat, and you treat them with growth hormone replacement. So this is usually injectable. Now, how about ACTH deficiency, or what we call secondary adrenal insufficiency? So we've emphasized earlier the importance of the HPA axis. So you can have adrenal insufficiency if your pituitary is out, wherein you have a low ACTH. However, in a hypothalamic disease, your CRH is out, your ACTH is also low, as well as your cortisol will also be low. Again, very non-specific presentation. There can just be fatigue, weakness, anorexia, nausea, vomiting, and hypoglycemia, which can happen in medical students taking their plating, right? But though this is non-specific, you have to take into consideration if these are present, okay, is there any other explanation? Because if there's no explanation, then I have to investigate further. Again, okay? So the etiology is usually, okay, a glucocorticoid withdrawal after treatment. So this is associated with suppression of your HPA axis. So remember, this one is very common. So you have to investigate if this is the cause, no? Or was there a surgical resection in your pituitary? That's why during the pituitary surgery, we usually give steroids because we know that this can happen. A mass effect, if there's a tumor in your pituitary, or there's a cellular lesion, then that can also cause an ACTH deficiency. Sometimes you can have a partial ACTH deficiency wherein probably there has been a problem in your pituitary, but still it's working. But during times of stress, patient undergoes surgery, patient is acutely ill, then you can have an acute medical, you can unmask this ACTH deficiency, and this can occur, this can give you full-blown ACTH deficiency. So again, how do you investigate? So usually we do a paired test here. So what you do, you have to get an ACTH and a cortisol together. And if your ACTH is inappropriately low, why is it inappropriately low? Because if you think about the negative feedback, if your cortisol is low, your ACTH should go up if the HPA axis is intact. However, if your ACTH is low, okay, or normal, and your cortisol is low on a basal state, then that can signal that there is ACTH deficiency. Now, if you wanted to confirm, then you can do an ACTH stimulation test or insulin-induced hypoglycemia, CRH, or methyropon test. So again, if it's low, low, then you can try to stimulate it, and if it doesn't stimulate, then you will have a deficiency. So what happens in your stimulation? Your ACTH remains low or inappropriately normal, and your cortisol will not go up. So that will tell you there is ACTH deficiency. Now the treatment is glucocorticoid replacement. Now some of you might ask, why not give ACTH? Because that is the one that is deficient. Okay, number one, um, ACTH comes in injectable form, and usually it's for diagnostic purposes. It would be very hard to give injections daily, and it's very hard to follow a circadian rhythm, so that's why it's not being used. Now, glucocorticoid replacement would be easier. So it's oral. You usually just take it once a day, or sometimes you can give it twice a day. If you wanted to follow the circadian rhythm, you can use hydrocortisone, a higher dose in the morning and a smaller dose in the afternoon. However, here in the Philippines, we have the prednisone that is widely used. So it comes, you usually give it just once a day. Okay, now we go to gonadotropin deficiency. Your FSH and LH are synthesized in your gonadotropin cells, which is about 10% of your anterior pituitary cell. The gonadotropin releasing hormone regulates its synthesis both of your LH and your FSH. And this gonadotropin releasing hormone is secreted in pulses every 60 to 120 minutes. However, this one will elicit also pulses in your LH and FSH. And in women, it will also cause you some circadian rhythm as well as monthly rhythms, because of, especially in the reproductive age group. So we will not discuss that in depth here. Suffice to know that you have an intricate HPO and HPT axis. So your LH and FSH in your pituitary both will stimulate your testis for the testosterone, and this will give you a negative feedback. And your LH, FSH, your ovary, okay, will produce your progesterone and your estradiol. These two will also cause a negative feedback, especially your progesterone. However, your estradiol, remember that increasing estradiol will stimulate, and a chronic estradiol will suppress. Now, when do you suspect there's a deficiency? If there are signs and symptoms of hypogonadism. This is the most common presenting feature of adult hypopituitarism, even when other pituitary hormones are also deficient. Okay, so most common presenting feature of hypopit. Okay. In premenopausal women, usually hypogonadotropic hypogonadism will present with oligomenorrhea and amenorrhea. Okay. And this in turn can cause infertility and decreased vaginal secretion, decreased libido, and breast atrophy in females. Now, in adult men, secondary testicular failure will cause decrease in libido, potency, infertility. You can have decreased muscle mass with weakness. The birth and body hair growth will be reduced. There can be soft testes, and there will be a characteristic fine facial wrinkles. And both men and women, because of its effect in the bones, can have osteoporosis. Now, how do you investigate hypogonadotropic or hypogonadotropin deficiency? Okay. Now, it's a simple test, also always a paired test, because somehow you will be able to interpret more if you do a pair test. It means that you get the pituitary hormone and the target organ hormone. So you somehow will be able to interpret them together if they are done at the same time. For central hypogonadism, what happens is that you have an LH and FSH that is inappropriately normal or low. Okay? Because this is the one that is deficient. Now, for females, it's enough to just check the estradiol, and usually this is low. And in males, you can check the testosterone, and usually it is low. If you wanted to test together, it's also okay. Okay, both should be low. Now, I would emphasize to you that you have to take you can take the confirmatory test by doing a gonadotropin releasing hormone test. And if you do that one, you try to stimulate your pituitary to produce LH and FSH and testosterone or estradiol. So after gonadotropin test, you will see that your LH and FSH will remain low or inappropriately normal, and your testosterone or estradiol will be low. So both of them, even on stimulation, will be low. Okay, how do you treat gonadotropin deficiency? So you try to think what is the end goal of the patient. And sometimes you have to address that some of them will not have their reproductive function back. Okay, so you will just have to address some of the other things like prevention of osteoporosis and also maintaining the well-being, the lean body mass. Okay, so those are probably your end goals for gonadotropin deficiency, because sometimes if there is already target organ that is very that has atrophied and very deficient, then you might not be able to salvage the reproductive capacity of the patient. So for males, you will just replace testosterone. If the uterus is intact and you think that the patient can still menstruate, then you give cyclical estrogen and progesterone. Sometimes if you wanted to restore fertility and there is a chance that fertility can be restored, then you can give gonadotropin injection in the form of human gonadotropin and human HMG. Okay, this is both for follicular growth and maturation, and HCG can induce ovulation. So these are the two that can restore fertility. Okay, but I mentioned to you earlier, if there is really, let's say, atrophy of the end organ, sometimes you will not be able to restore the fertility. So probably this one will be effective in those in the earlier stages. Okay, last we have the TSH deficiency. Now, the TSH deficiency, okay, so again, the TSH is synthesized in your thyrotrope, which composes about 5% of your anterior pituitary cells. Secretion is induced when negative inhibition by thyroid hormone is also removed. So again, due to negative feedback. Okay, this one is positive feedback. So thyroidectomy, radiation, coitrogens, or thyroiditis. So that's the one, okay, that may stimulate your TSH. Okay, so again, the pituitary causes TSH hormone secretion, and in your thyroid gland, it will induce the production or stimulate also your thyroid hormone release, and this will in turn cause a negative feedback. Now, if there is central hypothyroidism, it means that your TSH and your pituitary are out. Okay, this one is not being produced. you will have hypothyroidism. So the thyroid hormones will decrease. Now, usually this is less severe than primary hypothyroidism. The reason is sometimes if you take out your TSH, the thyroid gland somehow has um, some stores of your thyroid hormone. And without the secretion of your TSH, it usually takes time before all your thyroid hormones will be depleted. Okay, so it would take time. So the development of the hypothyroidism is usually not abrupt compared to when you take out your thyroid hormone, wherein there is abrupt cessation of all the thyroid hormone synthesis, then your symptoms are usually more severe. So that's the difference between a pituitary hypothyroidism or a TSH deficiency compared with primary hypothyroidism, wherein there is a deficiency of your thyroid hormone. So primary hypothyroidism will be more severe. How do you investigate? Okay, so you investigate by doing a paired test, checking your TSH as well as your thyroxine level. So what you will see is a TSH that can be low, although there can be a normal or slightly elevated TSH initially because of the hypothalamic hypersecretion. So it tries to stimulate. That's why sometimes you get this TSH in the early phases slightly elevated. But in the long run, you can have a normal or a low TSH. And the FT4 is low. Now, in the earlier discussion, we said that if it is hyposecretion, you have to stimulate. We rarely do it in the TSH because usually if you get this picture, then you're almost sure that that's the only thing that can cause it. Okay, so we rarely do the TRH testing. So we usually don't do a lot of TRH testing. Okay, so usually TSH low, FT4 is low, and that will be enough to document a TSH deficiency. So how do you treat? Okay, treatment is again thyroid hormone replacement. We don't give thyrotropin to replace a TSH deficiency. Again, it is injectable. It's not cost effective. Now, for thyroid hormone replacement, you usually, there's a few dictum that you have to remember when you replace the TSH deficiency. So you're using thyroid hormone, you have to make sure that the adrenal function is intact. So again, if you have TSH deficiency, there can also be an ACTH deficiency, especially if you have a tumor or other infiltrative disorders. So you have to make sure that you have adequate ACTH or adrenal function because the thyroid before giving TSH, because when you give TSH that is facilitating metabolism, then if there's concomitant adrenal function problem, then you can have a ACTH deficiency or adrenal insufficiency if you give the thyroid hormone first before replacing cortisol. So that's one important thing that you have to bear in mind in thyroid hormone replacement. So make sure that your adrenal function is intact before giving this one. So sometimes what we do is we give cortisol first, okay? And then later on, that's the time that we give thyroid hormone, okay? Now, the other thing is if it's TSH deficiency, you cannot rely on the TSH in the adequacy of your treatment because your TSH is low, okay? Or normal, inappropriately normal. so it would not change, no? So there's no, the negative feedback will not be effective, okay? So what you have to do is, you have to adjust the thyroid hormone levels, um, yeah, the thyroid hormone, your thyroid hormone replacement, no, your levothyroxine to the thyroid hormone level. So we usually just measure your free T4. You keep it at the normal range, and you have to ask if the patient are having signs of excess thyroid hormone, like thyrotoxicosis symptoms, or if there are still hypothyroid. So that's how you adjust your thyroxine replacement for TSH. So in summary, you will see here how we test for pituitary sufficiency. So for prolactin, okay, this one is TRH test. There's actually not really a hypoprolactinoma, so or hypoprolactinemia, okay, because you really have to suppress the prolactin. But for research purposes, you can do the TRH, and usually the TRH test is also done here. Okay, so if you wanted to check the integrity of your prolactin or your TSH, you can do a TRH test together. Now, the interpretation would be prolactin should be more than 2 microgram per liter, or more than 200% increase from the baseline. So that will tell you that the prolactin is sufficient. But to tell you honestly, I haven't done this test. Okay. Now, for growth hormone, insulin tolerance test. Again, you bring down the glucose to 40, the growth hormone should be more than 3 microgram per liter. So that's how you say that your growth hormone is doing okay. Now for ACTH, it's ACTH stimulation, so you have to have a cortisol that is more than 20 micrograms per deciliter. This is after stimulation, and an aldosterone of more than 4 nanograms per deciliter above the baseline. Okay, so we do the aldosterone because it has also an effect. The ACTH has an effect on your aldosterone, though the ACTH would not directly affect your aldosterone. For your TSH, just a paired test, or you can do the TRH, but just a paired test would be enough, and it should be within the normal range, or it's not inappropriately high or inappropriately low. Okay, so FSH and LH, so you just get also a paired test, LH and FSH for an estrogen for females, and LH FSH for and testosterone for males, and it should be within the normal range, age and sex adjusted. Okay, so you have to look at the normal level for the age of the patient and the sex of the patient. So because it differs. Okay. Okay, now how do we treat the hypofunctioning? So if you document that there are disorders or deficiencies on the different anterior pituitary hormone, how do you treat, or how do you replace? So for adult growth hormone deficiency, it's a growth hormone replacement. Okay, this is injectable. ACTH deficiency, so you give glucocorticoid replacement. Hydrocortisone is the nearest to cortisol, so that's the one that is being used. So more usually it's around 2/3 to 1/3 of the dose, ranging from about 15 to about 30 a day, depending on the weight of the patient. Now, for prednisone, which is being used here in the Philippines, this one is usually longer acting and has a less mineralocorticoid effect. However, the important thing that you have to note, if there is ACTH deficiency as well as even cortisol deficiency, is that since you don't have enough ACTH or cortisol during acute stress or illness, you have to double, triple them, or sometimes you need 5 times or more of their usual dose, okay, so that they will be able to fight off your illness or stress. If you don't increase the dose during acute illness and stress, they can go into adrenal crisis. Okay, they can get hypotensive, hypoglycemic. So this is the very important thing that you have to remember in ACTH or adrenal insufficiency replacement. Now for hypogonadotropic hypogonadism, okay, so the replacement would be testosterone for males. And for females, it's cyclic estrogen and progesterone with an intact uterus. Okay. Again, to restore fertility, you use the HCG, HMG. So that's. But if you wanted to restore, restoration of fertility, you can also use recombinant FSH and HCG for to induce ovulation. So this one is being used. Okay. For TSH deficiency, you give thyroid hormone or the levothyroxine. Again, important to make sure that there is adequate adrenal function before giving this one. Otherwise, you can go into adrenal crisis. And the adjustment should be based on the thyroid hormone level and the clinical well-being of the patient rather than the TSH. So don't, if you've already documented TSH deficiency, no need to test and retest the TSH level in the future. Okay, we'll just have a few minutes break, and then we'll go to the last part of our pituitary topic, which is the disorders of the posterior pituitary or the neurohypophysis. Okay. So the disorders of the neurohypophysis, okay, or the posterior pituitary. So neurohypophysis, because it's the continuation of your neural elements going to your posterior part of your pituitary. So we have two entities. One is hypersecretion and the other one is hyposecretion. So it is SIADH or syndrome of inappropriate antidiuretic hormone, and the other one would be diabetes insipidus. So this is the part of your posterior pituitary. You see it's more of neural elements rather than vascular. So because this is a continuation of your neural elements from your hypophysis. So your posterior pituitary will have mainly your antidiuretic hormone or your AVP, which has its main effect in your kidney tubules. Now, the oxytocin we've mentioned earlier when we talked about prolactin. Now, why am I mentioning this one? Because in supraphysiologic doses, the oxytocin will act like your antidiuretic hormone. That's why this is also very important for you to know that these two are present in your posterior pituitary and their functions can overlap. Your oxytocin, as I've mentioned earlier, okay, differs from your antidiuretic hormone or arginine vasopressin in only two positions, which is the 3 and the 8. It has a little antidiuretic effect, okay? And earlier mentioned for milk letdown during nursing, it initiates labor and stimulates uterine smooth muscle contraction. So in pharmacologic doses, if this is given to initiate labor and stimulate smooth muscle contraction to augment labor, then this little antidiuretic effect can be present, and this can also have clinical effects. Okay. Your arginine vasopressin, or your antidiuretic hormone, is derived from a polypeptide precursor that include your neurophysin and your copeptin. It is stimulated by your nausea. So in preparation for any dehydration, so you get a antidiuretic effect. Okay. Acute hypoglycemia, you know that this can have effect on your glucose release. Glucocorticoid deficiency can also stimulate, so that will be, this can also, because ADH can also have an effect on glucocorticoid release, glucocorticoid release. Smoking and hyperangiotensinemia can also stimulate ADH release. Its half-life is very short, around 10 to 30 minutes. And this is very important because if you have too much antidiuretic hormone, then you can have too much retention of fluid. Okay. Its clearance, though, is through degradation in the liver and your kidney. So if you have problems here, then you can have problems with the clearance. So 3 to 4 times increase during pregnancy due to a placental and terminal peptidase. Okay, so this one should be the increase is due to this N-terminal peptidase. Okay, increasing clearance. Now, the action of your antidiuretic hormone, or AVP, is to reduce water excretion by promoting concentration of the urine. So this is the main effect. So you wanted to retain water so that your urine will be, so what happens is that your urine becomes concentrated. So you're getting a lot of water. So antidiuretic, hindi ka pinapaihi. So this is most importantly through your V2 receptor. So I'm mentioning the V2 receptor because there is a drug that acts on your V2 receptor. Now the other effects of your AVP, okay, so arginine, the vasopressin side, will act on your smooth muscles in the blood vessels and GIT. This is important because we use this one, the AVP, the vasopressin side, in GI bleeding. Okay, so it causes vasoconstriction. It also induces glycogenolysis in the liver. That's why it's stimulated by glucocorticoid, and then potentiates ACTH release by your CRF. So in hypoglycemia, this can also have some effect. Now, let's go to inappropriate secretion of this ADH or SIADH. So this is a hormone somehow hypersecretion. So the syndrome of inappropriate antidiuresis, or SIAD, okay, usually SIAD presents with a very concentrated urine, and there would be excess water retention and dilution of the body fluid. So if there is excess water retention, what happens is you can have hyponatremia. So you are diluting the sodium in the blood. Now, if the hyponatremia develops gradually, there can be no symptoms at all. So it can happen several days, weeks to months. However, if it happens acutely, several minutes or hours, then you can have water intoxication. And this water intoxication can present with headache, confusion, anorexia, nausea, vomiting, coma, and Worse can be convulsions, coma and convulsions. If it is very severe, severe meaning very acute and very low sodium level, then it can be lethal. Okay. So your signs of SIADH usually are due to the hyponatremia that occurs with water retention. So what are the possible causes of SIAD? Because you can have a lot of ADH in your system, which is inappropriate, not mainly because there is a posterior pituitary tumor, but it can be a tumor elsewhere in the body, or it can be due to other things. So neoplasms of the lung, duodenum, pancreas, ovary, bladder, uterothymioma, mesothelioma, carcinoid, and bronchial adenoma. So almost a lot of all tumors, Ewing's and gangliocytoma. A lot of neoplasm can cause SIADH. That's why before we even say that it's mainly the pituitary, we think of neoplasms. Okay. There can be head trauma that can cause SIAD. There can be infections, especially pneumonia, abscess, aspergillosis, TB, meningitis, and this is encephalitis and AIDS. It can also vascular, so strokes, no? CV occlusion or hemorrhage, cavernous sinus, this is thrombosis. It can be genetic or congenital, so in children or infants, okay, they can also have SIADs. It can be a neurologic problem, GBS, MS, DT, and ALS. Okay, so Guillain-Barré syndrome, multiple sclerosis, delirium tremens, and amyotrophic lateral sclerosis. Hydrocephalus, psychosis, and peripheral neuropathies. Okay. It can be metabolic. It can be due to drugs like your anti-emetics, chlorpropamide. You can have carbamazepine, nicotine, phenothiazine, cyclophosphamide, anti-neoplastics, tricyclic antidepressant, monoamine inhibitors, SSRI, which are antidepressant, vasopressin, okay, desmopressin, oxytocin, and vincristine. So these are the possible causes. So when we label that the patient has SIAD, you have to make sure that you go over the list of the possible causes. The reason is you have to treat the primary cause of the SIADH to correct the SIAD. Now, SIAD is a diagnosis of exclusion. Okay, so that will cause the SIADH, but for you to diagnose that it is SIAD, you have to make sure that in your history, there are no history and physical examination. There are no signs and symptoms of congestive heart failure. So the heart is okay. The liver is okay. So there's no cirrhosis. There is no nephrosis or salt and water loss. So the kidneys should be okay. The ACTH and cortisol deficiency should be excluded. And there should be no nausea or vomiting. So these are important things that you have to take note in your history. So sometimes I get somebody who's hyponatremic and it's because they have nausea and vomiting. And then when you check the sodium again after the nausea and vomiting has abated, then you will see a normal sodium. So you have to make sure that you get this in the history. Now, on your physical examination, there should be no generalized edema. Okay, so this will be both your CHF, cirrhosis, and your nephrosis. There should be no ascites and there should be no postural hypotension. So there should be no dehydration. So SIADA is actually a hyponatremic that is euvolemic, normal volume. Okay. Okay, how do you investigate? Since it's a diagnosis of exclusion, you have to exclude all the things I've mentioned to you. Now, you also have to make sure that your sodium is not affected by your glucose because every elevation of glucose 2 millimoles per liter, or about 36 milligrams per deciliter of glucose increase in the blood, will cause a decrease in 2 millimoles per liter of your uh, will cause, yeah, a decrease in your serum sodium by 1 mg. Okay, so you have to correct the sodium first with your glucose before you say that that is the true serum sodium. Now, again, you have to make sure that you have to measure the urine sodium. You have to measure your renin activity, and you have to measure your BUN, creatinine, uric acid, sodium, albumin, and cortisol. Um, this will try to rule out your cirrhosis, your nephrosis, your ACTH deficiency, and your congestive heart failure. Now, the urine sodium should be high because your urine should be concentrated in SIAD. The renin plasma activity is low because your patient should not be dehydrated. This is one of the hormones wherein measuring the actual hormone will not give you a diagnostic value. So plasma AVP has no diagnostic value in measuring SIAD. So don't even measure this one, okay? Your BUN and creatinine should be normal, and uric acid should be low to normal. Okay, usually the uric acid, the blood uric acid, mimics somehow mimics your serum sodium in its level. So usually, to have a true serum sodium level, look at the uric acid. If it goes with your serum sodium, if it's low, then your BUA should also be low or within normal. Okay. Serum, uh, because their excretion is somehow parallel. So normal serums, potassium, albumin, and cortisol will eliminate your other problems like kidney, liver, and also cortisol deficiency. So how do you treat? Whatever the cause of your SIAD, for hyponatremia, due to SIAD, it would be a standard treatment protocol. However, for you to correct the SIAD, you have to correct the primary cause. So, for the hyponatremia, okay, of SIAD, you have to do fluid restriction. And by fluid restriction, it means that the input and the output should be the input should be lower by at least 500 cc compared to the output. And this will increase your serum sodium by 1 to 2% a day. So just fluid restrict. Okay. Now, if it is acute, wherein the patient is having seizure, has comatose, you have to act fast. You cannot restrict the fluid and say that the serum sodium will be corrected. No, it can be lethal. So what do? In acute and severe cases, you have to infuse 3% saline. Okay, because this will give you more rapid correction. However, okay, you cannot just infuse the hypertonic saline as fast drip or as fast as you can. You have to compute them, and you have to lower them by probably around 1 to 2 megs, no, per hour. And you usually just half correct them. Do not correct wholly, because after that, you can just do fluid correction, and after some correction, a patient will improve. Now, if you correct abruptly, no, you can have a potential for central pontine myelinosis, wherein this is irreversible. So what happens is that if you rapidly correct, okay, so the dehydration, okay, can cause an overhydration, that's why you will have swelling. And usually the most vulnerable portion would be the pontine area, and you can have melanosis. Central pontine melanosis will give you quadriplegia, okay? And some other cranial nerve problems. That's why somebody who just had lethargy and can be comatose but still active can end up quadriplegic, that is irreversible. So very important not to be overzealous in correction of your hyponatremia. But in emergency cases, you can still use saline, and you really need to use saline. So what are the other treatments from SIAD? Let's say you still, water restriction is not um, uh, causing a normal, will not normalize your serum sodium, or probably patient has cancer and the cancer is already inoperable, or you still are trying to figure out what's the primary cause of the SIAD. Okay, so you can do some other, you can give some other treatment like demeclocycline, which can produce a reversible form of nephrogenic diabetes insipidus. So the hypersecretion, you turn into hyposecretion somehow. Okay. The other one would be fludrocortisone, wherein there's an increase in sodium retention and plus inhibition of thirst. That's why you can correct the hyponatremia. And this is the one that I've mentioning earlier with this conivaptan, which is a V2VA antagonist. It's an AVP antagonist. Okay, so it will act as an antagonist to your AVP in the receptor level. That's why you can somehow correct the SIAD. Okay, so that's the treatment for SIAD. Okay, on the flip side, we go now to diabetes insipidus, or DI. Okay, so diabetes insipidus. This one is a syndrome characterized by the production of abnormally large volumes of dilute urine due to a decrease in vasopressin, or ADH. So what happens here is that you have large volume of urine because your ADH is no lacking. So if you don't have antidiuretic hormone, then you can have a lot of urine or fluid losses in your kidney. And what happens if you have lack of ADH, okay, large volume urine, which is very dilute. So, okay, you can present with this one. So, polyuria, okay. You can have urinary frequency, enuresis. You can have nocturia, sleep disturbance because you need to go to the bathroom a lot of times. You can have daytime fatigue because of the sleep disturbance, and also somnolence. You get very sleepy because of that one. Remember that large volumes of dilute urine to differentiate the polyuria that happens in diabetes mellitus. Because in diabetes mellitus, usually it's not that dilute as what you see in diabetes insipidus. Because of this polyuria, you can have increased thirst and polydipsia. Okay, so you're thirsty, you keep drinking water. And because there's no antidiuretic hormone, you repeat the cycle of polyuria, thirst, polydipsia. Okay. However, if there comes a time wherein you cannot drink, okay, to replace your the urine volume that you are excreting, then you can go into dehydration. Okay, and this can also be a presenting manifestation. So if at the time that you cannot have intake of fluid, you get dehydrated. Now, the etiology of a pituitary diabetes insipidus, because there's a nephrogenic, but I will not discuss the nephrogenic because that is in the nephrology module. So we'll just tell you about the difference between the pituitary DI in terms of its laboratory workup. For pituitary diabetes insipidus, a lot of the things that cause SIADH, okay, there can be an overlap with DI and SIAD. So one is head trauma, also neoplasm, which is craniopharyngioma, granuloma, histiocytosis, infection, inflammatory, like I've mentioned, lymphocytic hypophysitis, chemical toxins, vascular, pregnancy, and it can be idiopathic. So sometimes we really don't know what's causing the diabetes insipidus. Now, in younger age group, there can be congenital midline craniofacial defects. So this one usually they're caught when they are still babies. Or it can be genetic, wherein there is a Wolfram syndrome, which will have DI, diabetes, obesity. Okay, so this is a syndrome. So this one usually should be picked up when there are kids. Now, how do you investigate a diabetic, somebody who has diabetes insipidus? First, you have to document that they are really polyuric. So don't just tell them they go to the bathroom a lot of times. You really have to measure their urine output. And usually, you say it is polyuria if it is more than 50 ml per kilogram per day. So that's how you say that it is polyuria. You have to measure the 24-hour urine. Now, also, you have to get the urine osmolality. So usually it should be a dilute urine. So urine osmolality should be less than 300 millimoles per liter. So if you meet the criteria for polyuria and a dilute urine, that's the time you wanted to evaluate for diabetes insipidus. So how do you so this is somehow a deficiency of your antidiuretic hormone. If there is a deficiency, you try to stimulate. And to stimulate the antidiuretic hormone, you try to induce a dehydration or fluid deprivation test. So we just admit the patient and let them be dehydrated. Okay, you fluid deprive them. So how do you do the fluid deprivation test? So we usually just insert some we insert access to them, IV access, so that they don't go into severe dehydration, or so we can replace and get samples right away. Okay, so what we do is we tell them not to drink anything, okay, until we reach the certain criteria. Okay, what is that criteria? So they are fluid deprived if their urine osmolality will go into more than 300 millimoles per liter, a specific gravity of more than 1.01, and their body weight should drop about 5%. So usually the plasma osmolality, sodium would exceed the upper limit of normal. So if they're already fluid deprived, what you have to do is you give the antidiuretic hormone. Okay. If they're fluid deprived, you give the DDAVP. Okay. If there is more than 50% increase in the urine osmolality after 1 to 2 hours after the fluid deprivation test, then it is positive for a pituitary diabetes insipidus. This one is both a diagnostic and a treatment test, because if the response is more than 50%, you know that if you give antidiuretic hormone, the patient will respond. Okay, that's the meaning of the increase in urine osmolality after R. This is the differentiating factor for somebody who has a diabetes insipidus that is secondary to a nephrogenic cause or a problem in your kidneys. Because usually somebody who has nephrogenic DI will not respond by 50% increase in urine osmolality after 1 to 2 hours. So if we don't get this response, then it's a problem elsewhere, especially in your kidney and not in your pituitary. Okay. So how do you treat if it is diabetes insipidus and it's secondary to a pituitary problem? So what do we do? Okay, the DDAVP. So we give the DDAVP. It's a synthetic analog of the AVP. It's more resistant to degradation. That's why it's 3 to 4 times longer duration of action. So we usually give the desmopressin. This is injectable. Although there is an oral form, which is Minirin, that we use. Okay, we assess this one since we don't measure the AVP. If you look at that one, we don't measure the AVP. What we usually do is see if the response, if the polyuria and the concentration of the urine. So we give it to usually at night so that they don't go into nocturia, and see up to how long the patient will respond, and that's the time that we assess if we will give the next dose. Okay, so sometimes it can be given every once a day, every 24 hours. Some can extend to 2 days, or sometimes it can just be 6 hours that you really have to give. So it depends on the response of the patient on how you give the desmopressin. Usually, if the thirst is normal in pituitary diabetes insipidus, you prevent the water intoxication. That's why we don't give the DDAVP on a specific time basis without assessing the polyuria of the patient. Otherwise, if you just give them one injection every 24 hours, you can go into water intoxication, because sometimes it can be more, the effect can be more than 24 hours. Or sometimes if the desmopressin is given like every 4 or 6 hours, then you can have a lot of water retention. So you have to assess the response of individual patients so as to prevent the water intoxication. However, the thirst is very important parameter, because during the time that the patient is thirsty, that's probably the time wherein you have waning also of the effect of your desmopressin. Okay, there are summary cases here that you will be discussing later on. If you have questions on your pituitary disorders, it will be answered after going through the summary cases. The summary cases will entail somebody who has a pituitary tumor, pituitary mass, and you have to answer what are the possible symptoms, how you go about diagnosing it through laboratory imaging, and how to treat them. So after these summary questions, then you can have further discussion with your respective proctors, assigned faculty, who will be discussing on things that you that need further attention. Thank you.